I'd like to introduce Professor Calum Semple. He is a professor of child health and outbreak medicine at the University of Liverpool in the UK, and he's also a consultant respiratory paediatrician. And he's going to be talking today about the ISARIC, is that right? WHO Clinical Characterisation Protocol and how data can save lives.
Ladies and gentlemen, it's indeed an honour to be speaking to you today. And for those of you who didn't come to the big data session, you missed out a really good session, including a talk by Laura Merson, who explained the fundamentals of how we set up ISARIC. So I'll give a very brief recap of that just to help you, bring you up to speed. So in 2009, there was a pandemic of influenza. At that time, not a single clinical trial, randomized controlled trial of an antiviral, or in fact any other agent occurred apart from a plant-based remedy in China. So we still don't know if oseltamivir works in a real-world clinical setting. An observational study was led by Professor Jonathan Van Tam in England called FluSyn, and it got off the ground quite late in the first wave. And a study led by Peter Openshaw did biological sampling, and that only managed to open to recruit at the tail of the second wave. But as I said, not a single clinical trial happened. Out of frustration, ISARIC, the International Severe Acute Respiratory Infection Consortium, was born. And Laura explained how that was set up by Jeremy Farah and runs now globally, I'll get this right now, Laura, 137 countries, and it's 60 networks. Got a thumbs up. Now, the secret to our success is that the networks have got day jobs. They might be looking at neglected tropical disease in one area, or it might be an intensive care network in a well-developed country. But these are research-active clinical academics and public health agencies working in partnership on an existing problem that's relevant to their country. So they have the processes in place to collect data. They're up to speed with how to take consent. But on the shelf at the back of the office, gathering dust, is a protocol that was developed by ISARIC in 2011 or 2012. You can find it on the web. It's open access. It's open to anyone to use, including the case report forms. And in China, in 2019, Chinese investigators used the case report form to start gathering data about what was then called Wuhan flu. I'm going to talk to you just about the UK's activity, because that's the one network that I'm in charge of, but I'm only one of 60 other networks. But I'm going to explain to you how we leveraged that data to inform public health policy in the United Kingdom. So, oops, sorry, wrong button. So we did two things. We gathered data that we collected without consent. We got a special exemption from the Secretary of State to gather and share personal information without consent from the healthcare records, connect it to public health data held by, for example, national immunization data sets, join it up with ONS cause of death, and use that data to make rapid analysis. The second thing we did was much more radical. I mean, if you think it's radical taking clinical information without consent, wait till you hear this. This traditional model for research is that you get an academic center of excellence working with the local hospital where a lot of their doctors have got honorary contracts, and they collect 20 patients and they guard the samples and they work on them in secrecy, a bit like Gollum in the Lord of the Rings. And it's my precious, it's my sample. And they work on these 20 samples and they produce a paper which they don't preprint, and they send it to 3 journals, and 18 months later it's published. And by that time the pandemic's over and lots of people have died. So what we did was very different. We got the networks to agree to send their samples to Liverpool and to Glasgow. Liverpool was considered a demilitarized zone. We were not Oxford or Cambridge or London. Therefore, we were not expected to be such centers of academic excellence that we were going to hoard the samples and produce the Nature papers. And as soon as we got the samples, we aliquoted them typically into 10 samples, but we got samples of urine, stool, blood. The blood came in PAX gene tubes. We also had samples for white cell extraction and serum and plasma and respiratory swabs. And we aliquoted these down as much as we could. So the blood went into at least 10 aliquots. And we then sent these aliquots to the people that needed them most at the time, which at that time, and I'll go through who these were, but essentially it was 20 institutes throughout the United Kingdom that were working on building standards for the WHO CEPI international standards. And we sent them to the people trying to develop the antigen tests and the PCR tests, and people that are validating a bunch of rubbish tests that have been purchased by dodgy contracts and turned out not to be very good. And in fact, that negative work, we had a talk a couple of days ago about negative work. It's terribly important to discount the dodgy tests that don't work, because if you use dodgy tests and tell us that Miles hasn't got COVID when he really has, Miles goes to work and gives it to everybody in his lab. So these negative results were really important. So at the end of the pandemic, we had clinical data on 300,000 patients, and we'd collected biological samples from just under 3,000 patients, but from them generated 35,000 samples, which have been sent out to people that really knew what they were doing, and therefore they could do powered studies. And now I'm going to tell you about what we actually did with that data. So on the left-hand side of my talk, I've got the major impacts that the study had. And on the right side of the screen, I'm going to present the individual papers. So this panel was our very first report to Cabinet Office. And the Cabinet Office received data through something called the Scientific Advisory Group of Experts, or SAGE. And this was our very first report. And it showed on a circle a patient. And if the circle was clear, the patient was discharged alive. If the circle was red, they were dead. And if they were black, they're transferred to another facility. So this was the first paper to SAGE on the 11th of March. I didn't get to celebrate my birthday on the 10th of March because I was up writing this paper. And that was the first bit of really strong evidence that we could say to Cabinet Office, this is a disease that is mostly killing elderly people, but actually there's quite a lot of people between 50 and 75 of working age who are not geriatric or not frail elderly, and they've died too, by the way. We need to watch out. So that was important early data. And as that data was fed in iteratively, within roughly 30 minutes of getting a nurse uploading the data in a hospital, that data could be analyzed. And we built dashboards and developed multinomial regression models, which were dynamic. And that's what this is here. And that's one of the models that came out within about 6 weeks. We had enough data to generate a very solid model. And we were able to show very clearly that age was the strongest predictor of poor outcome, that being female was strongly protective, and some new features such as obesity as being a very good predictor of a death too. And it turns out that although hypertension is important, it's the multimorbidity that leads to hypertension that is actually more important. So in fact, when you do the model, hypertension falls out. And what you really need to know is somebody obese or got diabetes or got chronic cardiac disease or chronic pulmonary disease. So again, this model then became very important because that could then identify the vaccine prioritization groups, and we'll come on to that soon too. We fed to Cabinet Office through SAGE these what we call demographs. They're upside down population pyramids for epidemiologists. And again, they show a sort of spinning top shape to the demograph in wave one. And the spinning top is heavier at the top because more elderly people are affected than younger people. The only reason it gets smaller at the very top of the men is actually the men have all died off by that point. But more men are affected than women, and more men are dying than women, and relatively few children. And that was wave one. But as we heard in wave two, things changed. And for reasons that have still not been explained, we started to see an excess of morbidity, not death, but morbidity amongst women of reproductive age. And that signal came out very early in wave 2. That's still not been explained. Some people said it was because they were school teachers or shop workers and because society had opened up again. But I'm still not entirely satisfied that that explains that. It could be that there was some changes in the viral tropism. The next thing that our data was used very early on was to identify what was happening to people in the hospitals. So they were coming into hospital, but we could use this data to show, did they go to the ward on day 1 or did they go to the intensive care unit? So we showed the disposition in hospitals across their length of stay. And then modelers in our Department of Health could very quickly work out how many ventilators were going to be needed in the United Kingdom. And very quickly, there was general panic, actually, realizing that we were going to run out of ventilators very, very quickly. So this data was very useful early on in identifying that there needed to be massive expansion of our intensive care units. And we closed routine surgery very early on. We emptied out the routine surgical areas and expanded our intensive cares, used anesthetic rooms to provide routine intensive care. And some of our operating theaters were actually converted to 4-bay intensive care units. And we could use these alluvial plots to show where patients arrived through the front door. Some went straight to the intensive care units, most went to the wards, but after day 1, some got sicker and went to intensive care. So this kind of plotting was very useful. We could show how many patients required oxygen. That really should read high flow oxygen, because in the United Kingdom, we don't prescribe oxygen. So nasal cannula oxygen, you just forget about it, but high flow oxygen is recorded in the notes, those that required intensive care and those that required non-invasive ventilation. So this kind of granular data then helped us plan, could we get away with using non-invasive ventilation rather than a traditional ventilation machine? We sent samples to NIBS, who developed the WHO international standards. So the first 5 standards that were used then globally came from this study in Britain and were sent out globally to help develop the assays that were used. That was a major contribution. We were able to then send samples to Emily Adams, who was developing a novel antibody test and also assessing the use of other lateral flow tests by other groups. And again, that led to the discounting of several million pounds worth of lateral flow tests that had been purchased and then had to be put in the bin. We sent material to Sarah Gilbert's team, and she used that to check on the immunogenicity of the vaccine that she was developing. So again, that was quite a useful thing to do, to be able to provide the control material for the Chadox vaccine. This was a commission that we got over a weekend from the Cabinet Office. In the press, there was a lot of talk that Sarah's vaccine wasn't working. People were saying this vaccine doesn't work. People are getting the vaccine, they're still getting COVID. And the Cabinet Office said, could we disprove this? So we started gathering data on the interval between vaccination and the onset of symptoms in patients admitted to hospital. Now, the Chadox vaccine had been tested in young, healthy adults, and the antibody responses in them and their rate of infection have been very well described. But in the real world population, a lot of the adults are older, and about 3% of them are on immunosuppressive therapies. So the real world data could be expected to be quite different from a study in young, healthy adults. And indeed, it was the case that people were getting COVID after being vaccinated. But when you looked at the time between the interval of vaccination and the onset of symptoms, there was a rapid drop-off after 2 weeks. You see, you're vaccinated here, your symptom onset, pretty static for the first 2 weeks. and then it starts to drop off. And anyone that's done biology knows that it takes a couple of weeks for a vaccine to start the immune response. So what we could actually show here is the reason that some people do get COVID after vaccination is it's just too early for that dose to have started working. And this provided a great degree of satisfaction and confidence. But it also allowed us to change the message, because it turned out that a lot of silver surfers were coming in, a lot of active elderly people were coming in to get their vaccine and then saying, right, I've had my vaccine, I'm going to Bridge Club, or I'm going to get back on Tinder. You know, stranger things happen. So it turns out the message has to be, you're going to get your vaccine, but it doesn't kick in for 3 weeks. So just hold your horses a wee bit. Now that, you couldn't have predicted in 2011 that our study, which was designed to identify who gets disease X, what does it look like? You couldn't have predicted that we'd be used to answer this question and provide that kind of answer. Our study provided the seed virus for the human challenge study that changed the paradigm understanding the period of infectivity. And this was a critically important study because it showed that the confidence interval for onset of infectivity was between 2 and 4 days. So 90% of people become infectious or have detectable virus in those between 2 and 4 days after a human challenge, not the 5-day incubation period that was stated at the time. So I'll say that again, 90% of people are infectious before the onset, before the median onset of symptoms. And that was a public health message that hadn't got across. Most people were being told, if you don't have symptoms, you're probably okay. Actually, most people are actually infective before most people show symptoms. And that message never got across. And I don't think that message landed well with public health policy teams. This will be, yeah, that's true, isn't it? Yeah, thanks. Yeah. Yeah, but it didn't land on policy. No, that's the problem. And then another really strange thing happened. I got phoned up by a lovely research nurse called Amanda Odom from Edinburgh, and she said she's tearing her hair out. The research nurses are really upset. All the medical students and nurses that are filling in your case report form are getting muddled up. They're filling in the symptom onset day on the admission day, and the admission day on the symptom onset day. And what's worse, they're getting worse at it. More of them are making this mistake. And we said, well, that's very odd. Why are they making this mistake? They weren't making a mistake. People were being admitted, and they were getting their symptoms after they're being admitted, because these people were being admitted with heart attacks and strokes and broken legs. And what the research nurses and medical students were doing correctly was saying, well, they got their symptoms on day 7 after admission, and they came in with a broken leg. Well, we'll fill in the form. This was the first and strongest signal of hospital-acquired infection in the United Kingdom. And within 30 minutes of checking the data and getting this right, we were able to land the information with the DCMO, and the next day it went to SAGE. And sadly to say, the problem got worse. We never actually properly addressed this in the United Kingdom. But we discovered that hospital-acquired infection was a major problem and probably led to further onward amplification of the pandemic in the community, because as people were catching COVID in the hospital and being discharged, they were then becoming infectious into the community. We looked at this data in great detail. The plot on the right-hand side shows hospitals on the bottom axis by how busy they are. So these are hospitals that are small and hospitals that are big and busy. And these are the proportion of patients that are infected. We've got a median line here. And you can see that there are some very big, busy hospitals that have got low hospital-acquired infection rates and some that have got egregiously high infection rates. And these circles are for the general hospitals. The triangles are for residential nursing care homes, and the crosses are for long-term mental health units. Now, you'd expect to get higher levels of hospital-acquired infection in a long-term stay facility because the patients are there for longer. So it's still a tragedy. It's still a failure of infection prevention control. It's nothing to be proud of. It's shameful. Our motto is first do no harm. So it's shameful that's happened. But what this data shows is that it is possible to be big and busy and maintain the highest standards of infection control. And what we failed to land with our policy teams, we failed to get action to learn from this activity to improve this for subsequent waves. So we had failures as well as successes. So that was another failure in our policy. The publication, the data got to the policymakers within 30 minutes of us spotting it. It actually took 17 months to get that paper published. And we never got a satisfactory action. We got to proofs with the British Medical Journal, and then for reasons that have been never explained to me satisfactorily, they decided to pull the paper. And you do begin to wonder if some aspects of embarrassment about what was happening in the NHS had influenced decisions of a paper that is actually funded by the trade union for the British doctors, might have influenced their decision to publish. Professor Chris Whitty, a man who I hold in the highest personal and professional regard. Much the way that Tony Fauci worked with Donald Trump, Chris Whitty has worked with Boris Johnson, and really the man is a hero. But you can see him using our data here in a press conference, explaining the shape of the data and consequently using that to inform prioritization of vaccine for older groups, but then get across the message that still about a third of the patients affected are under the age of 50, and that's why it's so important that we get these important, economically important groups vaccinated. So we inform that process as well. Our data was used to define the groups that remained at the highest risk of severe COVID outcome despite vaccination, despite shielding. And those were the ones that were chosen to get early access to monoclonal antibodies and antivirals when these worked. Not that they work so well now. We were also able to use the data to check on whether hospitals were starting to use dexamethasone, which had been recommended by the recovery trial. So we could look at the patient data and say, and this graph shows the uptake over time. And we did land this very well. This is some data that did land well, because we could then say, this hospital, for reasons we cannot explain, is not using the national guidance. And then the Department of Health could send in a hit squad and say, why is your hospital not giving dexamethasone to these patients? And often they'd say, oh, we don't like giving steroids to old people because it makes them go a bit loopy. And we'd say, well, we'd rather they went loopy for 5 days and saved their lives, so please give them the dexamethasone. And that targeted intervention actually landed very well and would have saved lives. This is Professor Kenny Bailey, another hero. Kenny works in intensive care units. He's a founder member of ISARIC. He did a whole genome-wide association studies and meta-analysis of the human genome of the 3,000 patients that we brought into ISARIC, and I think about 20,000 patients in a study called Genomic. And by looking at polymorphisms in the human genome associated with severe disease, he identified about, I think it's about 20 polymorphisms that are important. One of them is type 2, and this is a polymorphism that sits on the JAK-STAT pathway. The reason that's important is because drugs exist that modify that pathway. The drugs happen to be drugs for rheumatoid arthritis. If you turned around and said, I've got a drug for rheumatoid arthritis that I'd like to try out in a patient with COVID, we'd have said, you must be crazy. Where's your evidence? Here's your evidence. So a drug that you'd have never taken off the shelf was identified as possibly therapeutic and got added to the recovery trial. And within, I think, 6 weeks of being added to the recovery trial, was shown to have a 25% increased survival benefit than dexamethasone alone. So this was a drug that could be added to dexamethasone and give you an additional 25% survival. And if there's someone that deserves an honor. It's him, because he saved tens of thousands of lives. The study, our ISARIC study, fed data into ISCAP cancer study on CCP and the long-term long COVID study, which is now ongoing. And COVID has now identified 5 long COVID phenotypes, which have got biomarkers which clearly identify them. So long COVID is a real thing. Don't start thinking that long COVID is the modern equivalent of yuppie flu. Long COVID is real. They've identified 5 phenotypes, 4 which are systemic and have some overlap, and 1 which stands alone, which has got neurological features. And FOS-COVID may then be able to develop therapeutics for that too. So Patrick Vallance, our government chief scientific advisor, has gone on the record and said that our study has captured a large proportion of UK hospital cases and proven extremely useful to both SAGE and SPI-M. SPI-M's our modeling group, and it has been vital in identifying risk factors associated with poor outcome and the early signs of the prevalence of hospital-acquired infection. Now, it's really interesting that he focused on hospital-acquired infection, because he knows that that did not land well with the policy team. So he's actually setting that up quite nicely for a discussion in the public inquiry that's going to be coming forward. So the problem in 2009, a lack of clinical trials, clinical research starting too late, observational public health research starting about 6 months into the pandemic, and consequently not informing policy. In comparison, here's the shape of the curve in the UK over time, and we managed to get the very first 2 patients. It's not COVID. We managed to get the very first 2 patients admitted into our study, and then all the patients from the Diamond Princess into our study as well. So we did very well there. And that study is called ISARIC, and that's the study I'm talking about now. We also got clinical material to the right people in time to do the right work, and we're very proud of that. And the clinical trials were run by Peter Horby and Tony Gordon, doing the recovery and the remap studies. The big question is, how did we do it? And the answer is, it was a very, very collaborative process. Every single hospital who gave us data, we guaranteed that the clinical lead and the data nurses, if they wanted to be identified, could get their names put on the research papers. So there was a doctor in Bolton who had the first patient with a variant of concern, let us know about it. That sample went straight down to Wendy Barclay and got put into getting made ready for seed for one of the human challenge studies. And that kind of attention to the people on the ground who are gathering the information is how we got the buy-in from our clinicians across the UK. And that's really what made the study such a huge success. So because of that, I want to finish by thanking the 2,648 research nurses and medical students and clinical staff who helped us to collect the samples and data at a time when their parents, their grandparents were dying, and they weren't being able to go out socializing, and they were having a really tough time. And that's the story of ISARIC 4C. And thank you very much.
Thank you very much for a great presentation, a truly incredible piece of work at a very challenging time. I think a very important reminder as well that when we talk about social behaviour, we often think primarily of the general public, but what happens among the scientists and among the policymakers is also social behaviour, and that the importance of collaboration and facilitating that to make this work. So thank you.